Okay. Great. So I'm so happy to be here. Thank you again, Sigfus, for the introduction and for your whole team for the invitation to be here. I'm really excited to share a little bit about my work on inner speech. As you heard in the introduction, that's where most of my energy is focused in the lab at the moment. And today I'm going to be talking to you about a study that we recently completed asking whether we can use inner speech to predict naming treatment outcomes among individuals with aphasia. So I love to get people on the same page before I do all the talking. So I'm going to have you all do a little self-reflection here for a moment. I'd love you to spend just a few moments thinking about some of the things that you did this morning, maybe what you did before starting your workday, and a couple of things that you've gotten done at work, if that's what you've been up to today. And then keep going, but maybe switch over to thinking a little bit about your plans for the weekend, something you're looking forward to. And then just another moment or two, shift your attention to thinking about a loved one, a family member, friend, pet, someone that brings you some joy. And what I'd like you to do is think back to the 60 seconds or so that I just gave you a couple of prompts and try to identify what your thoughts were composed of. So maybe you were thinking mostly in pictures. You were visualizing images related to the topics I suggested. Maybe you were thinking mostly in written words, actually seeing things written out in front of you, or mostly in spoken words. You might have been hearing language or speech in your own voice or in someone else's voice that felt like spoken words inside your head. Maybe you had a mix of these, maybe different topics prompted different modalities of thinking, or maybe each topic combined words and pictures, something like that. Maybe you have something else altogether. There's lots of evidence across various fields that the modality of thought can differ across individuals and even within someone, depending on what they're thinking about and what the purpose is. But one key modality we're going to focus on today is inner speech. So if you found yourself thinking mostly in spoken words, it's likely that this is what you were experiencing. So let's get on somewhat the same page about what we mean by inner speech. But I'm going to be very unsatisfying and start by telling you that there is not one definition of this phenomenon. As I mentioned, inner speech is studied and thought is studied across many disciplines, including cognitive neuroscience, but also things like philosophy, linguistics, sociology, etc. So given the various lenses on inner speech, it makes sense that there's not one single definition. One trend that you'll see if you do dive into this literature is that the definitions for inner speech tend to encompass either a subjective or an objective approach to understanding the phenomenon of inner speech. And I don't think I said this, but I have IS as the abbreviation for inner speech. You'll see that throughout the slides. So if you're thinking about the subjective facet or component of inner speech, you might see a definition like this: the ability to generate language silently in one's head or to talk to oneself in one's head. And this is really focused on the person's experience. So this ties into what I had you doing just moments ago, thinking about various topics and reflecting on whether you were doing so in words. That might be a sense of having talked to yourself in your head. But another more assessment-based or objective way of defining inner speech looks something like this. So this is an example from several decades ago now by Levine and colleagues, where they defined inner speech as the objectively measurable ability to appreciate the auditory articulatory structure of speech, irrespective of its meaning. So I'll give you some examples in a moment of how these two definitions of inner speech can be studied in scientific research, and that'll help to elucidate the differences between the two definitions. So if you're interested in inner speech, you may focus on self-report. This would be the more subjective emphasis. And here you may have individuals come into a lab and do various things like silent recitation of tongue twisters or silent picture naming, or you might ask them to report on their inner speech as they're going about their day. So there's a technique called ecological momentary assessment, but there's also other things like journaling and just interviews where you can ask people to reflect on their day and tell you what their experience is in terms of their inner speech. The other, more objective or assessment-based definition for inner speech can be measured through tasks that are considered a proxy for inner speech. So this doesn't tell us exactly what's going on, but can give you a sense of how much information is actually there in terms of phonology internally. So these are tasks that usually are based on written words or pictures, and you ask the individual to answer some questions about those, like look at these two words and tell me whether they rhyme, do they sound the same, show them a picture and ask them to say the name in their head and tell you how many syllables it has, things like that. So everything I'm showing you here is behavioral. I'm not going to be talking about any imaging today, but I'm hopefully conveying that there are lots of different ways to measure inner speech. And this is done in the literature in both healthy individuals and also in some disordered individuals, which is my segue to I'm here to talk about aphasia. So why are we interested in inner speech in this population? So I'll show you a video. This is a research participant from my PhD days who gave me such a perfect answer to an interview about inner speech that I'll probably never stop using this video. So you'll hear me ask a question and hopefully hear her response.
Do you ever know what you want to say, but you can't say it out loud?
Yes.
Please describe that feeling.
My head is saying it, but my mouth not saying it at all.
So I love this definition for a couple of reasons. One, she is demonstrating her use of gestures alongside her speech to make sure that her message is clear. But she really highlights this mismatch that those of us who work with individuals with aphasia hear about all the time. There's something in my head that I can't get out. She says it so clearly. My head is saying it, but my mouth is not saying it at all. Another direct from stroke survivor way of thinking about this is this set of images that shows sort of a Pinterest-worthy display of the sentence in my head, and then maybe the execution not so nice when I say it out loud. And this image was shared at one of Temple University's stroke survivor groups by Angie Cawthorn. Again, many years ago now, but I saved these because I think they're really great illustrations. And I can't mention Angie without putting in a plug for her podcast with the late Dr. Celeste Gadsden. If you have not listened to it, please do. They have great conversations and there's a lot to learn there. So overall, I've told you that there is interest across various fields in the phenomenon of inner speech. And I've now told you that in aphasia, there's specifically this mismatch that's often reported where someone says the inner speech is there, even when the out loud speech is not. And so I think for many of you in the audience, I saw the folks who were trickling in, I saw many names. For many of you, you probably don't need this refresher, but I am going to walk through a model of naming that's pulled together from the components of many published models that helps us think about how is it possible to have successful inner speech even when the out loud speech isn't successful. And I have to say, I gave a presentation along with my research SLP to our participants from the treatment study to share with them a little bit about our findings. And I previously had this model as a very academic looking, like box and arrow model, all gray with very complex terms. And I simplified it and made it a little bit prettier for the folks with aphasia, and it was so much nicer that I just can't bring myself to go back. So you'll see this is a little bit simplified, but I think it's a little bit nicer to look at as well. So we're going to build a model of naming here. The idea is you're seeing a picture or an object. You want to be able to name that out loud. What do you have to do to be able to do that? So first, you need to be able to recognize the object or the picture to know what it is. and tie it to semantics, some concept that represents that image. After you have the concept, that gets mapped onto phonology. This is usually thought of as the abstract phonology, in the sense that these are the abstract sounds that make up the label for the concept that you've just retrieved. After that, the phonological form that's abstract needs to be specified and prepared for articulation. So this blue circle that says output processing represents things like phonological assembly, putting the sounds in the right order, maybe phonemic specification or phonetic specification, where you're choosing the specific sounds based on the word you're going to say, how they relate to each other. So this is moving from abstract phonology to more specified sound forms to prepare for articulation, which is where we're actually saying that word out loud. So I've got a couple of different steps here. They can be broken down into two main categories. One representing word retrieval, so that's mostly semantics and phonology, and then the other is combining to form the output portion of the naming process. So once you've successfully performed retrieval and output, you can say the name of the picture out loud. So this is true for all of us who are using language on a day-to-day basis. This also applies to folks with aphasia. And what we see often in aphasia is that there's some component of anomia or difficulty with this process. And what we're able to observe on the surface is that the last stage is not successful of actually saying that word out loud. And so what happens is we're not easily able to determine exactly what's going on in all of the stages before. This is easily observable. They don't say anything at all, or they make an error when they're trying to say this word, but we have a little work to do to figure out what's happening at the stages beforehand. The reason why I brought up this model and walked through it is because I think it helps to explain the phenomenon I mentioned before, where individuals with aphasia feel this mismatch, where their inner speech is intact, even when their aloud speech is not. And so just to be really clear about what I think is happening there, we can place inner speech here at the boundary between retrieval and output. So once someone has retrieved the semantics and phonology, the sound that labels that concept, they have an internal monitor or an inner loop from the Levelt model that's able to bring that word to awareness. And they have a sense of successful inner speech. And then something happens during the output processing or during the articulation itself that leads to that mismatch, where even though they might be able to say cat in their head, they're not able to say it out loud. So that is my broad background to get everybody on the same page about what is inner speech, why is it relevant in aphasia, how is it possible, and where I'm going to go from here for the next 30 minutes or so, leaving time for questions, I hope, is to tell you a little bit more about what's known about inner speech and aphasia. The study I'm presenting today is not the first one, so I'll tell you a little bit about my own prior work and the work of some other research groups. I'll share the questions and hypotheses we hoped to address with the current study. I'll tell you how we did it, what we found, and where we're headed next. So let's start with the background. The first thing that I can say is that there is mounting evidence that people with aphasia not only say they know more than they can say out loud, but we think that there's some validity to that. So there is evidence that people with aphasia do know more in their head than what they can say out loud. The first study that really supports this is from almost 50 years ago now by Goodglass and colleagues. They didn't study inner speech per se, but they looked at the tip of the tongue experience in people with aphasia and found that in most individuals, barring a couple subtypes, which I'm happy to answer questions about later, in most individuals, when they said they had the word on the tip of their tongue, even when they couldn't name it out loud, they were usually able to answer questions like, what's the first letter? How many syllables does it have? And they did better on those questions than for words that they couldn't name out loud and also said, it's not even really on the tip of my tongue. About 10 years after that, Feinberg and colleagues looked specifically at 5 folks with conduction aphasia, and they found that there was, again, a mismatch between aloud speech, which was here based on oral reading of written words, and their ability to make judgments about those words. So an example of this would be they might be able to look at two written words and answer whether those words rhyme with each other, even if they're not able to successfully read those words out loud. So neither of these were looking specifically at inner speech. They don't use that term in either paper, but this is some preliminary evidence for that mismatch that's often reported. The first study that I did on this topic was an interview-based study where I asked people with aphasia about the experience of inner speech, specifically during anomia. So what I was getting at here was not inner speech and then they could go on to say the word out loud, but specifically this experience of I can say it in my head even when I can't say it out loud. And I asked people to tell me if this happens to them and to answer on a rating scale how often it happened. And the first finding was just that people reported this to happen. It was common. More than 3/4 of the participants said, yes, it happens. Many of them said it happens almost all the time. And my next step from that was to relate the reports of this mismatch to things that we think it should relate to. And as I mentioned before, we think that inner speech reflects intact word retrieval with deficits somewhere in the output. And so we found two things that matched our predictions. One was that frequent reports of this mismatch did relate to poorer output processing. And also that frequent reports of this mismatch related to lesions in the left sensory motor cortex. So this is the region of the brain that we think should support output processing. And so through both behavior and lesion location, we were able to find two pieces of evidence supporting the reports that we got on the interview. There were some limitations to this study as well. It was considered preliminary in nature, but a really nice first step. So what I did after that was move beyond a general interview, just asking, does this mismatch occur to you, to ask specifically about intact inner speech at the level of individual words during a silent picture naming task. So anyone who works with aphasia knows confrontation naming tasks. You show a picture and they say it out loud. What we did was take it one step sort of before that, have them look at the picture, try to name the picture in their head, and then answer the question, just yes or no, can you do that? So we usually define this as, I want you to try to name this picture in your head with all the right sounds in the right order. And if you can do that, press yes. And if not, press no. If it doesn't sound exactly right, don't give me a yes. And so folks are able to do this. And in a prospective study versus the previous study, which was retrospective in nature, in a prospective study, I was able to design a number of other tasks that we thought should relate to these reports. Again, testing the hypothesis that successful inner speech, as experienced by the person with aphasia, should relate to retrieval. And the sort of spoiler for the next couple of slides is that we found a lot of different sort of converging pieces of evidence that successful inner speech does relate to word retrieval. So you'll see some citations at the bottom from papers that came out of this work. The first finding showed that self-reported inner speech at the level of individual items was related to lexical features that relate to retrieval. So words that were reported as intact in inner speech were usually higher frequency words, but there was no relationship to aspects of the words that related to output. And so this was our first piece of evidence showing that successful inner speech relates to retrieval, but doesn't require output processing. We also found that it related to performance on inner speech-based tasks. This sort of went back to the good glass work that I told you about. For words that participants said, I have it in my head, they were better at telling the first letter and the number of syllables. So if they looked at a picture of a pineapple, they could usually give us that information if they told us they could say it in their head, versus they look at an armadillo and they say, no, I don't even have that in my head. They weren't able to give us that sound-based information. And so this was two pieces of information at the item level that supported our hypothesis that inner speech reflects retrieval. And then we also asked this question at the participant level. So for people who tend to report a lot of successful inner speech, not necessarily at the level of items, but just for people who report this often, we found a relationship with overall lexical retrieval ability, but not with output ability. And then also we found that these participants tended to produce more frequent phonological errors. So I didn't specifically set up this prediction, but the prediction here was that if individuals are retrieving these words, but they're not getting them right out loud, something in their production might give us a little insight into the knowledge that they do have. And so you can imagine, if I go back to the example of the armadillo, they might be producing some of the syllables, or maybe they say that word with a couple of substitutions or something like that, that shows us they have that word in their head, even though they're not naming it out loud. Something about their production is telling us maybe they do have at least some of the word in their head. So that's a very brief summary of the prior work that I have done in this area, but I'm not the only one who's investigated this in the last decade or two. So my work has focused primarily on self-reported measures of inner speech and then tied that to assessment-based tasks. But some other researchers have focused primarily on assessment-based proxy measures for inner speech. And so that's what I'm going to show you here. There's a group that defined inner speech as creating an internal representation and applying a computation to it. So this is like those silent rhyme judgments or homophone judgments. And they found that relatively preserved inner speech can be found alongside otherwise severe production deficits among people with aphasia. And so this builds on, for example, the work from Feinberg many decades ago showing that oral reading ability was not as strong as the ability to answer questions about those words. So this was a similar finding to that. The last piece of background I'll tell you about before I dive into the current study is that there's one study in 2 people with aphasia that was sort of retrospectively performed that showed that self-reported inner speech at the level of specific words predicted 2 important things. So one, when participants said they could say words in their head, they were more likely to name them out loud, which makes sense. That's the first step. So for a lot of people with aphasia, they have the word in their head and they can say it out loud. And then in other moments where they had the mismatch, they retrieved the word in their head, but they weren't able to say it out loud. My colleague William Hayward asked how that related to treatment outcomes. And he found that for words that were reported to be successful inner speech items, those individual words were learned more quickly and more effectively overall during a paired associate treatment for naming. And so the outcome there suggested that what someone says about their retrieval prior to treatment might have some bearing on the outcomes of treatment, which is really attractive. I think many of us here work in clinically relevant research, and so we're interested in ways to help speech pathologists make decisions about clinical treatment planning and treatment design. And so knowing that something about this phenomenon of inner speech is potentially predictive in treatment planning is exciting. And so that led to the questions and hypotheses that we're hoping to address in the current study. I know there was a mention at the beginning that questions could come up in the chat, and I do see some coming in, and I will absolutely make sure that I come back to these at the end. If anybody has like a clarification question, feel free to unmute and interrupt me. Otherwise, I'll come to all of these at the end. Okay, so the primary question that we're addressing in this work is, does self-reported successful inner speech predict naming treatment outcomes in post-stroke aphasia? And I've shown this model a couple times now. As a reminder, the prediction or the hypothesis is that inner speech reflects intact retrieval, and a failure of naming after that is coming in at the level of output processing. And so our specific hypothesis to be tested here is that words that are reported as successful inner speech are closer to successful naming output because they're successful here and here. The output deficit is just at these last stages. So they're closer to successful naming, and so those should be learned more easily during treatment compared to words that aren't even being successfully retrieved. And of course, this depends to some extent on the type of treatment that's being administered. And so I think that this hypothesis is particularly salient when the treatment is specifically focused on output processing, which is how we've designed our treatment here. So to address this question, we executed a single subject design treatment study. It was specifically an alternating treatment design, but instead of alternating between two different types of treatments, we designed the study to alternate between two types of items. So the two types of items, hopefully if you've been tuned in, the two types of items shouldn't be a surprise. We were comparing between words that were reported before treatment to be successful in inner speech versus those which were not reported to be successful. So you'll see the abbreviations here of SIS for successful and UIS for unsuccessful. And I want to make sure I say right now, in case some questions come up later, that when we have unsuccessful inner speech items, sometimes the person actively pressed no, I can't say that word in my head. But other times that person just didn't give a response and they timed out on the question. So maybe they were still searching for that word, still putting effort towards retrieval, but didn't get there in time. So successful inner speech is, yes, I've got it. It sounds right in my head. And unsuccessful inner speech is, no, I'm not able to get there, at least in the time that I'm given. So the way that the study worked in terms of the timeline, I'll come back to this timeline at least once more, but I think it's a great place to start, is that we had an initial week of testing. I'll talk through each component in more detail, but we had an initial week of testing. Then we chose their treatment items. We did baseline testing specifically on the treatment items before treatment began. Treatment was 2 weeks, 5 days a week. And then we had 3 time points for post-testing, right after treatment, about 1 month later, and about 3 months later. The first day of testing was done in person, and then we sent the participants home with a computer, and every other day of testing was done virtually, but live with an SLP. So the research team for data collection was myself and 2 other speech language pathologists. We made sure throughout the study that treatment and assessment were always done by 2 different people. So no one was doing both assessment and treatment for any individual participant. The first week of testing, I'm not going to belabor the details here just for the sake of time, but on day 1, we gave a detailed battery of speech and language testing, including an introduction to the concept of inner speech. And then on days 2, 3, and 4 of that first week, we gave the tests which allowed us to choose the treatment items for each individual person. So what that looked like was a list of 271 illustrations that were administered on 3 days in 3 different orders. And each time they saw the picture, they were asked to try to name the picture in their head, press yes or no to answer whether they could do that, and then go on to say the word out loud. So the outcomes from each day were a list of inner speech report, successful or unsuccessful, and then a naming accuracy, yes or no. What we did during our week off before baseline testing was scramble to score and evaluate their outcomes to choose their unique treatment items. Each participant had a different set of items based on their performance during initial testing. And to qualify for the treatment, participants who did the initial testing needed an adequate number of incorrectly named items, which we defined as incorrect on at least 2 of the 3 days. And our goal was 40 items total, which I have in another bullet on the slide. But what we ended up setting as our absolute minimum was a minimum of 12 words that were not named out loud that were reported as SIS, and a minimum of 12 words that were reported as UIS. And so this allowed us to have an even number of SIS and UIS items and enough items per person to ask meaningful questions about the outcomes. As I mentioned, our initial goal and plan was to have 40 treatment items per person. And so what we did was include some filler items that matched the main treatment items as closely as possible to get up to 40 items for each person. And by match the treatment items, I mean they weren't very often named out loud, and they were either SIS or UIS as consistently as possible, but maybe didn't meet our main criteria for consistency in those categories. So I didn't put these numbers in the presentation, but we had one participant with 12, one participant with 15, and then the other three had either 19 or 20. So we did have a couple folks who were reduced, but some of them were able to meet that 40 item target. Our participants are shown here. We had 8 that were enrolled into the study, but 3 who are grayed out didn't meet the criteria. One of them had naming scores that were too high. You can maybe guess who that was with the SWAB AQ score here. So their overall naming ability was too high. They didn't miss enough items. And I think the same thing was true actually here for P009. And then for P006, there wasn't an adequate balance of SIS and UIS items, even though they got enough items incorrect overall. So we ended up with 5 participants in the study, and I'll give you a moment just to look at their demographics and their WAB subtypes. I realized this morning that I didn't put this on the slide, but in terms of race and ethnicity, we didn't have any Hispanic or Latino participants. Everyone was a monolingual English speaker or was a English speaker from birth. And we had 2 participants who were African American and 3 who were Caucasian. So a little bit more about the methods because I think the treatment is important to be clear about. Then I'll tell you how we analyzed the results and what we found. So the treatment was 5 days a week for 2 weeks. It was all virtual, but again, live with an SLP, but it was delivered on the computer. So it was set up to be really consistent across participants. And it was a hierarchical queuing based treatment that was honestly pretty boring, but very, again, standardized and consistent across people with many opportunities for production. So the person saw the picture and had a 4-step hierarchy of cues. First, they were asked to name the picture independently without cues. Then they were given the written word and asked to name the picture out loud. Then they heard the word and were asked to repeat it. And then they were shown the picture and asked to name it after a 5-second delay for a little bit of working memory involvement. So there was a 5-second limit per step. And if the name was incorrect, they were given the opportunity to repeat the word. Again, even though they were live with the SLP, the words were recorded, and so they didn't see the SLP produce the word, they just heard it and were asked to repeat it back. And so for each item, they named it at least 4 times and up to 8 times if they were having trouble and had to try to repeat each time. So there were lots of opportunities for output built into this. And each item was actually treated twice per session. There were 2 blocks of SIS items and 2 blocks of UIS items that alternated in the session. That's the alternating component of the design. And the order started with either SIS or UIS, and that was counterbalanced across participants and across sessions. So for testing, we did 3 days of baseline testing to choose, or once the items were chosen. So before treatment began, we did 3 days of baseline testing. I think I actually have so I have the timeline here. So we did 3 days of baseline testing before treatment even began. Then we did probe testing every other day during treatment and post-testing at the 3 time points I mentioned. You'll see some counts down here of how many items were tested on each day. And we were interested in capturing generalization. We don't expect a lot of generalization based on the focus of the treatment being so repetition and output based. But we wanted to be able to capture it if it did occur. So you'll see that on 2 of the 3 days at each testing point after treatment, they tested actually we tested the whole set of 271 items. But on one day, we gave the participants a break and we just did their 40 treatment items. We were trying to balance here between capturing a lot of good information, but also not wearing our participants out. So to analyze the outcomes, our primary outcome variable was naming accuracy after treatment, with our primary time point being that immediate post-testing time point. So this was done usually the Monday, Tuesday, and Wednesday after treatment ended. Our primary measure was tau-u, which is a measure of effect size that can show changes in accuracy from baseline to post-treatment. And we used tau-u to calculate changes separately for SIS items and for UIS items. Tau-u was our measure of choice because it allows us to account for changes during baseline testing which I can show you an example of when we get to the results. And our prediction was that each participant would show significant learning for SIS items and potentially not for the UIS items, as our prediction was that this should work better for the SIS items. Those should respond better to treatment. Our secondary analysis using Tau-U was to assess maintenance at 1 month and 3 months post to see if any learning that occurred during treatment was able to be maintained. So that was the planned analysis, but I really want to make sure I mention here that there was a second plan to do another analysis that would take into account other factors that we know impact learning. So inner speech report is a variable of interest in this study because it's novel, but there are so many things about words that we know impact whether they're learned during treatment. And so these include lexical features like length and frequency. So what we also did after using Tau-U at the individual level was to perform a model in the entire group of participants to assess findings at the level of individual stimuli while accounting for individual variability. So this allowed us to assess multiple predictors of learning, not just inner speech report. And so I'll walk you through exactly what that looked like. Our dependent variable for the linear mixed effects model was the number of times that each item was accurately named during post-treatment testing. So that was a score ranging from 0 to 3. The predictors were our fixed effects, of course, included inner speech report, our main variable of interest, 4 other variables related to the items: frequency, length, orthographic neighborhood density, and age of acquisition. And then we also included aphasia severity measured by the WAB-AQ as a fixed effect. And we included a random effect for participant to account for individual differences. Okay, I think I said everything I need to say there. So I'm going to move on to the results. Again, if you have questions that are just for clarification, feel free to unmute and ask those. I'm happy to answer those as I go. I don't think I see anything new in the chat, so I'll do my teacher trick of pausing to take a drink and give people a moment to think. But I'll move on to the results. I'm just checking where we are on time. Okay, great. So for the results, I'm going to show you just 1 or 2 examples of the individual figures showing learning across time. I'll give you the Tau-U results. This was our primary outcome measure for significance and effect size. I'll show you the main question of immediately after treatment, and then also the maintenance data for 1 month and 3 months. I'll show you the results from the linear mixed effects model, which allows us to consider those other word variables. And then I think I've got a couple hidden slides in here that I'm happy to show during the questions, which are figures showing changes over time, not just in naming accuracy, but in inner speech report, which I think is a nice illustration of sort of the changes in the gap between retrieval and output over time. I left them out for the sake of time for the talk, but I do have them if anybody is dying to see those. Okay, so I have our first participant who was, the first person to complete the study is the one that I'm going to walk you through what their graph looks like. And some of you might be familiar with single subject design. Historically, one of the primary ways to analyze single subject data was through visual analysis of graphs like this. We now have some statistical measures that allow us to do a more formal analysis too, but I think there's a lot to be learned by looking at the graphs. So I'm going to show this to you first. And just to orient you to what you're seeing, you've got accuracy on the y-axis. So this is the number of treatment items that were named correctly. You'll see the scale differs by person. Some people have only 12 or 15, so the scale might not go up to 20 for everyone. And then across the bottom, you have time. So there's the 3 sessions of baseline testing. And remember, these were not the days where we chose the treatment items, but once the treatment items were chosen, we tested those specific 40 items again 3 times. The 5 days of treatment probes, and then the 3 time points of post-treatment testing. Last thing is successful inner speech is going to be shown always in blue, and unsuccessful inner speech is shown always in red. So for P003 at baseline, you can already see a difference in performance for SIS items versus UIS items. And I mentioned that tau u can account for trends at baseline. And so I think this is a really nice place to illustrate that. You can see that for the UIS items, P003 on day 1 named 3, and then 8, and then 9 items. And so that's an upward trend in performance that needs to be accounted for, because if you look at treatment, you can see that there is this sort of continuing upward trend, at least for the first 2 days of treatment, that doesn't actually look that much different than what's happening just with testing. And so what tau u allows us to do is sort of hold items like this or sets of training materials like this to a higher criterion to be able to actually show learning. So the main time point of interest is this P123 immediate post-testing, where you can see just in terms of level on the graph that both SAS items and UIS items are being named at a level that's higher than what they were doing at baseline. So just visually, it looks like there's some learning that's occurring during treatment, a little bit more consistent and predictable maybe for SAS items versus the UIS items, which are a little bit more volatile, at least during treatment. And then just for completeness, I'll show you the maintenance data for this person as well. So you can see, again, if you're just looking for level, you can see that the SAS items come down a little bit over time, as do the UIS items. And then, of course, a question that tau u will answer is whether these are significantly different than where they were at baseline. So just to show you one more example, we have P005, who also, interestingly, shows that same upward trend during baseline testing just for UIS items. And then after only 1 day of treatment, jumped up almost to ceiling and basically stays at ceiling for naming throughout the rest of the study. So those are two really different patterns. And we have, different ones I could show you for the other 3 participants, but for the sake of time, I'm going to switch over to the main results. So our primary outcome measure was tau u, and I'm going to show you for SIS and UIS for each of our 5 participants was learning successful from baseline, or was learning significant from baseline to post-treatment testing. So the first primary finding is that for 4 out of our 5 participants, there was a significant change in accuracy from baseline to post-treatment testing, and not for any participant for UIS items. We had 1 participant, and that's P007, where there wasn't any significant learning from baseline to post-treatment testing for any items. But for 4 out of the 5, it looks great, learning for SIS and not for UIS. For post-treatment maintenance, also using tau u, you're going to see the same thing, 1 month post for SIS and UIS. And at 1 month, the results actually look really similar to immediately after testing, where for our same 4 participants, there was significant learning for SIS items. But then interestingly, for P008, he also showed a significant level of learning for UIS items. I don't want to call this maintenance because he didn't actually show this pattern at immediately post-testing, but something has happened over time where the performance on those items is significantly different than it was at baseline. And then for the 3 months maintenance, in our participants who showed good outcomes early on, that was maintained for 2. So they have successful learning for SIS items again at 3 months post compared to baseline. And then our 2 sort of outliers over here have interesting things to show. One is that P008 is still showing a significant level of learning for UIS items after 3 months, but the learning has dropped back down for SIS items. And then really interestingly, P007, who didn't have any successful learning at any other time point in the study, has now shown up with some significant learning for UIS items at 3 months post. So I'm going to summarize what I've told you so far. We did find that SIS items were learned at a significant level, so more effectively than UIS items for 4 out of our 5 participants. I do think that the lack of successful learning in UIS items is significantly impacted by baseline trend, and I'm happy to talk more about that if anybody wants me to. Learning of SAS items was effectively maintained in all 4 at 1 month post and in half of them by 3 months post. And then interestingly, we've got this non-responder P007 who had a significant level of learning for UIS items at 3 months post, but no learning anywhere else in the study. And she is an outlier in that she had the most severe aphasia and apraxia of speech out of the group. She's not completely different from P008, but she is just a little bit more severe. And so we've got some ongoing analyses to figure out what's going on with her. But what I want to tell you about last before I wrap up is the group analysis. So I mentioned that we know other variables predict treatment outcomes. So what's going on with these? Our question here is, does inner speech report predict the number of times that a specific item will be named correctly during the 3 days of post-treatment testing? And we predicted that words reported as SIS would be named accurately more often after treatment. We did a gut check here, and just looking at the means, the mean accuracy for SIS items was higher than UIS items. The first time I did this in Excel, I had the columns backwards, and I thought that I had the exact opposite result, so I'm very glad I don't. But just in terms of raw means, SIS accuracy was higher. But what the linear mixed effects model is going to allow us to do is incorporate inner speech report as a predictor alongside the lexical features that we all should also know should matter. So the results for this are going to be shown in a table here. So you'll have the p-value over in the right column, and the predictors are listed here. So we have inner speech report, our 4 lexical features, and then severity. And remember, the participant was included as random slope, so this accounts for individual variability. And here's our result. So it looks great. The overall model is significant, and we had 2 significant predictors, lexical frequency and inner speech report. So what this means is that words that were reported as SIS at baseline were more likely to be named correctly after treatment. Words that were higher frequency were more likely to be named correctly after treatment. And then there was also a trend that participants with milder aphasia had more accurate naming overall. So this might have become significant with more participants or more data points, but at this point it's just a trend. So this is great. This is, I think, what I just said. Naming accuracy after treatment was significantly better for items that were reported as successful inner speech. And this is our key prediction. And this provides converging evidence with the results of the Tau-U analysis to show us that our prediction held true, which is great. So I have just a couple slides left with some discussion items and future directions. I'll try to get through these in just 2 or 3 minutes so we've got time for questions, because I know there's at least 1 or 2 in the chat. So the study that I've told you about today builds on a growing body of literature that suggests self-reported inner speech is meaningful among individuals with aphasia. The key finding here is that inner speech predicted treatment outcomes in 4 out of 5 individual participants. And in a model that considered other lexical features, which are objective aspects of the stimuli, which we know should matter, inner speech was still a significant predictor of treatment outcome, along with lexical frequency in our model. These findings align with the small prior study by Hayward and colleagues that I mentioned, where there were 2 participants with aphasia who had differing outcomes based on inner speech report. And there's also a recent group level study by Bree Stark and colleagues using semantic feature analysis and having a similar result, where successful inner speech before treatment has some predictive value in indicating what's going to happen after treatment in that study. So I think there's some clinical relevance to this work, and there's not going to be enough time to talk about it in great detail, but I love to, so feel free to reach out if you want to chat more. But the key takeaway, I think, is that, as I said, self-reported inner speech during silent picture naming seems to be a predictor of treatment outcomes for at least some folks with aphasia at the level of individual items. I think this is really an important takeaway because asking people to report their inner speech is simple and efficient during a naming test that you're already doing, as long as you're not trying to give a standardized score. During a naming test that you're already doing, you can add an extra step to have the person tell you yes or no, whether that word is in their head. And if it does continue to be shown that this is predictive of treatment outcomes, it may be the case that clinicians can choose items for treatment based on this information. And so one way to think about this might be if we know that words that are already being retrieved are going to be learned more easily, maybe you want to focus on those first to sort of get as much progress early on as you can. Or in contrast, you may not focus so much on those because you know they're going to be easy to get back, and you might focus on some words that aren't even yet being retrieved so that you're treating kind of that earlier stage of the process and trying to maybe get some benefit that boosts through the whole naming process. So I think there's lots of discussion that could be had on exactly how this information would translate into clinical decision making, but I think there's a lot of good insight that can come from it. The other way to think about this is that patient insight into retrieval can help clinicians identify what types of cues will be beneficial. So I mentioned Angie and Celeste's podcast. There's also a podcast through the Stroke Comeback Center, which is here in the DC area. It's called The Slow Road to Better, and it's also great. So feel free to check that out as well. And they had me on many years ago now. And one of the stroke survivors who was hosting the podcast that day really latched onto this idea and was basically saying, like, you know, if I have pineapple in my head, but I just can't get it out, and my clinician is sitting there going, it's a fruit, it's a tropical fruit, it's spiky. I'm like, yeah, I know. Let's get to the part I actually need help with. And so I think, you know, clinicians can get that information based on other things like error types and patterns throughout testing. But I think specifically asking people about their inner speech report can kind of be a quick way to identify for this word, this person doesn't need this type of help. They might need this other type of help. And I also think asking the person directly just gives so much self-efficacy and so much validation to the patient or client, which I think really goes a long way for buy-in and motivation. And then the last thing I'll say is that I think in general, um, we're focused here on one type of treatment and differing impacts for different types of items, but the other way to think about using inner speech for treatment planning is maybe that different types of treatment are going to be more beneficial for different items or even for different individuals who tend to have more intact inner speech or not. And I know the group at South Carolina has done some work in recent years on predictions of different types of treatment outcomes. And so I think that's definitely something that this could contribute to as well. So last thing, there's lots of ongoing analyses here. I won't read them out loud just for the sake of time, but we're planning lots of other things here. We're looking at inner speech and executive function. We are looking at inner speech in Spanish, English, bilingual speakers with aphasia, everyday inner speech. We definitely want to do more treatment studies. So lots more to come. I hope to be able to share more with you in future years. And then I just have my thank you slide here. So Haley Anderson and Erin Ann Cardman are the two research SLPs who helped me with data collection. Could not have done this without them doing that, especially with the maternity leave in the middle of the treatment study. We've got mostly undergraduate research assistants in the lab, so especially Charlie and Joelle here in the front row in their graduation crowns have done tons and tons of work on analysis for the study. I have two statisticians at GW that contributed to helping me execute the models. And my work was funded by a K-12 grant. This was a 2-year training grant. And I had Leora Cherney as a mentor for the single subject design component, which was really invaluable. And of course, our participants, we couldn't and wouldn't do this work without them. So we always make sure to thank them for their time and their effort. So I definitely didn't leave a lot of time for questions, but I did leave a little. So I'll put this slide up. It has my email address and the lab's email address, and I'm more than happy to answer questions. So yeah, sorry, go ahead.
Sorry, thank you so much, Mackenzie, for a great talk. If we had a live audience here, they would be clapping for you right now. We do have time for a couple of questions, and I see we have a couple in the chat. If you want to maybe just read it out and answer
Sure.
from there.
Sure. So it looks like Kirana asked a question early on, and she said, I wonder how much the inner speech is actually a metacognitive judgment, such as the feeling of knowing, studied in healthy populations. How are these two different phenomena different? Both involve the stage of phenology and self-monitoring that brings awareness to the internal failure. So that's a great question. And in the first study that I shared, I mentioned it was an interview-based study where I asked people about this experience of I can say it in my head, but I can't say it out loud. And in that study, we actually used the feeling of knowing separately. So in that study, we gave 3 examples. One is I can say the entire word in my head and I know what it is. I can hear it. It sounds right. And we differentiated that from what we called in that paper the idea without the word, which is like the feeling of knowing, which is I have a general sense of what it is, but I can't think of the word. And then we actually even threw in tip of the tongue, which I think lies somewhere in between the two. I think you're exactly right that there are aspects of self-awareness and self-monitoring that are required to identify any of those phenomena. And I think one of the things that's really tricky about this work is that I think there are probably individual differences in sort of the level of like what the criterion are internally, what the criteria are for them to kind of achieve which of these. And so one of the things that I feel is likely true is that some of my participants in the past in this current treatment study are saying I have the whole word in my head and it sounds exactly right, but their criteria are a little bit different. Some people might be a little bit more lenient, like, well, I have most of the word, and that's so different from not having the word at all, so I'm going to go ahead and say yes. Whereas other people are more self-critical. And we know this is true for out loud naming as well. And so it makes sense that there would be differences both in monitoring ability and also just sort of leniency and self-leniency for both. So it's a great question. I'm happy to talk more about it, but it's something that I think about a lot. And then I saw that you added a question about bilinguals. That answer seems to be true. Right now, we've only run 2 case studies, but in both of them, they both have really different language backgrounds and it's really complicated. And, we could test 1,000 people and they would all be totally different in terms of their language status between the 2 languages before and after the stroke. But in both people that we've tested so far, they seem to experience similar um, presence or absence of this mismatch. So we've got one person in our study who really has a frequent mismatch where her retrieval is almost fully intact, but her output processing in both Spanish and English often fails. And so she's got a lot of phonological errors, a lot of attempts at self-correction. She demonstrates a lot of knowledge of the words, but isn't able to kind of get a score of yes on a naming test because of her errors. And that seems to be true across both languages. But then, of course, there are overall differences in language abilities between Spanish and English for her. And that's true for our other person, too. All right, so I see we're right at 12:30. So let me see Lindsay's question. I'll read it out and then give it an answer. If people have to leave, please feel free to leave. But the question from Lindsay is, thanks for a great talk. I enjoyed your discussion of how this can be implemented clinically. Have you thought about implementing this type of research in the clinical setting, or do you have any idea of how clinicians across settings might be considering this type of approach, especially across the continuum of care? So I think it's a great question. You asked it towards the end, so you may have asked it right as I was giving my clinical relevance slide. So I'm not sure if I answered a little bit of that with that slide or not. But I am really interested in figuring out how this would happen in a real clinical setting. When I was first starting out in research after being in SLP for many years, and I did treatment research as a PhD student very minimally, was like, I'm not doing any more treatment research because it doesn't look like the clinic. So like, how could it ever translate? So it is really important to me now that here I am doing treatment research. It's really important to me to figure out how we do the translation and the implementation of the work that we're finding in the lab. And so I think one of the things that I have seen happen, because I've given talks about inner speech for a while now, is that I have SLPs tell me, I'm going and asking my patients or clients about their inner speech, and it's interesting. So I think just starting the conversation is kind of the first step to implementing some involvement of inner speech report into the clinical setting. And I think SLPs just being able to tell their clients like, hey, there's evidence that you're feeling that it's in your head is real. You're not imagining that. I think that can be really validating. So I think that is already just one way to get this research evidence into the clinic to some extent. But I'm hopeful that in the future, I'm going to be able to collaborate with clinicians and help provide kind of more concrete ways to think about how and when to ask about inner speech report and exactly how to make those decisions. Like I said, I think the tricky piece is um, there's some branching logic of if you know this, where do you go from there? And I think it depends on your client and your goals, how long you have with them, how far they are post stroke, their self awareness, et cetera. And so I love the idea of working to help answer some of those questions and give some guidance. But I think it's going to be pretty complex and there's a lot of nuance. But that's one of the things that I love most about it. So thank you for the question. And I see you said happy to chat further. I would love to do that too. Okay, I think that's all the questions that are in the chat. I'm going to end my share just so I can see something other than my slides. But I'm happy to answer other questions if people have them that they want to ask out loud. If anybody has anything else to put in the chat, feel free. And I'll also just type my email address one more time in there. I love to talk about this, so happy to answer questions. Thank you.
Perfect.
Thanks for your questions, Kirana.
Thank you so much, Mackenzie. This puts us at the end of today's talk. And like Mackenzie said, if you have more questions, feel free to reach out. But thank you so much for joining us today. And thanks to our online audience for watching and asking questions. We look forward to seeing you at the end of summer for our 10th season of the C-Star Lecture Series. Until then, have a good summer.
Thank you. Thanks so much for hosting.
Thank you so much.